Good afternoon, everyone. Welcome to the latest Queen Elizabeth Scholarship webinar brought to you from the McMaster Health Forum at McMaster University in Hamilton, Ontario. Here's an agenda for today's webinar. I will tell you a little bit about the McMaster Health Forum, a little bit about the Queen Elizabeth Scholarship Program, and then I will turn things over to our outgoing intern, Young Lee, who went to England and worked with the National Health Service. The McMaster Health Forum is a leading hub for improving health outcomes through collective problem solving. They harness information, convene stakeholders, and prepare action-oriented leaders, and act as an agent of change by empowering stakeholders. The Queen Elizabeth Scholarship Program is run by a partnership between the Rita Hall Foundation, Community Foundations of Canada, Universities Canada, and individual Canadian universities. The purpose is to activate a dynamic community of young global leaders across the Commonwealth to create lasting impacts both at home and abroad through cross-cultural exchanges encompassing international education, discovery and inquiry, and professional experiences. The Queen Elizabeth Scholarship Program offered by the Forum is called Strengthening Health Systems. Our scholars contribute to Strengthening Health Systems and become part of our large and growing network of health system leaders. We've had two cohorts so far. Our first cohort, which is listed here, primarily went away or visited us in 2016. And our second cohort, which is listed here, primarily went away or visited us in 2017. Our third cohort begins in January with our first person going to Uganda. Our scholar today is Young Lee. At the time of his internship was in the Bachelor of Health Sciences undergraduate program here at McMaster. During his undergraduate career, he developed an interest in public health, evidence-informed practice, and governance. The goals of his internship was to deepen his knowledge in healthcare commissioning and delivery, healthcare leadership, and primary care policy and decision-making. He is currently still at McMaster, however, in the Michael G. DeGroote School of Medicine, no longer an undergrad. So Young, I will turn it over to you, and enjoy.
Thank you, James. Thank you so much for having me, and thank you everyone for coming and listening. My name is Young, and I'm one of the Queen Elizabeth Scholars this year. And like James said, I'm currently a first-year medical student at McMaster University, and I have an interest in health systems research, evidence-based policy development, and clinical epidemiology. So today, I'll be talking about my experiences as a Queen Elizabeth Scholar in London, United Kingdom this summer. And the overview of the presentation will be the first part of the presentation, and I'll talk about some of the projects that I was involved in, and lastly end off with my overall experience. So, my internship this year started around mid-April to end of July, and it was a self-arranged internship where I had to find an institution that was able to take me on as a QES scholar and be part of a project as a visiting student. So my internship was at NHS England, which is located at central London, and this is the building. It's called the Skipton House, as shown below. So this building is very interesting because inside there is, of course, the NHS England. It also has Public Health England, as well as the Department of Health in UK. So this building really is a primary hub, a place where a variety of important decisions about the healthcare system in the United Kingdom is made day to day. And specifically in NHS England, there are multiple departments, and the team that I worked with primarily was the National Primary Care Team, which is responsible for developing policies and programs for general practitioners, about 60,000 general practitioners all across the UK, and to improve primary care in England nationwide. So what is NHS England? So to give you a brief overview of NHS England, it is an executive non-departmental public body of Department of Health, and it oversees a variety of aspects of the UK health system, as it oversees the budget, planning, and delivery and day-to-day operation of healthcare commissioning in England. So it commissions contracts to general practitioners, specialists, pharmacists, as well as dentists. And each geographical region in the UK is divided into clinical commissioning groups, also called CCGs, which are a group of general practitioners and physicians that plan and pay for local services such as hospitals and ambulance services. So to contrast with Canada, Canadian healthcare system is, of course, a publicly funded and privately delivered system, as physicians are not hired by the government, but the UK health system actually is different because physicians are commissioned, in a way hired by the government. Also, the clinical commissioning groups, the CCGs, are in a way very similar to Ontario's local health integration networks, where specific geographical regions are allocated with specific funds so that they can distribute it evenly to the general population. So my overall goal of the internship was divided into professional goals, academic goals, as well as personal goals. So under the professional goals, I really wanted to learn how to participate and play a role in a governmental institution and learn how to conduct research on university settings, because all of my research background before has been at McMaster in a very academic setting. So it was a really new experience for me to go to NHS. And lastly, I also wanted to learn how to draft a policy proposal or also just be involved in the process of decision making as well as program development. So for personal goals, I wanted to really learn how to work and live in a different country for a longer period of time, because I've never actually lived away from home for more than 92 days, like the QS program right now. And I also wanted to form meaningful networks and with the people in the UK health system, and also engage with UK Canadians as well as other QES scholars. So during my time in NHS England, I was part of multiple projects, and I'll go through them bit by bit in detail. So this is the overview of the projects. So the first project was measuring the effect of 10 high-impact actions on releasing capacity for care. And I'll talk more about 10 high-impact actions throughout the presentation, but measuring the effect of those 10 high-impact actions in NHS was one of the bigger projects that I was part of. And secondly, I had a role of increasing database for case studies and reviews in the General Practice Capacity Forum. Third, to review different web-based portals and apps in the UK healthcare system. And lastly, help assist and facilitate discussion during these 10 high-impact action events. So before I talk about my project specifically, I want to give some background. So the general practice in UK, the NHS England specifically, is under considerable amount of pressure. So there is this rising volume and complexity of workload. There's constantly rising running costs in the NHS. And while workforce and investment have not really kept pace with other parts of NHS, so there's lots of pressure happening. Thus, NHS is really committed to stabilize and make general practice more efficient and allow it to fulfill more of its potential at the heart of NHS. So the NHS, after conducting some research, they interviewed lots of practice managers, physicians, and they found out that one of the most burdensome issues in primary care is first, getting paid, and because when physicians bill for their services, there are many ways of reporting and claiming for their payment. So it's very different from Ontario or Canada in the sense that you don't go to OHIP, which is a single payer. So it's quite confusing for physicians at times. So it can be quite burdensome for the physicians. And also, it's hard for them to keep up to date with incoming information from commissioners and other bodies at a national level. Because NHS, because they in a way hires these or commissions these physicians, physicians are always getting these emails, bulletins, letters, and all these information which they cannot keep up along with their practice. So continuing the research aspect, so they interviewed about 56 general practitioners from different areas of the United Kingdom, and they reported that about 26% of the appointments could have been handled differently. So on top of this pressure, there are actually 26% of the appointments that could have been handled differently, which could save lots of time for the general practitioners. And moreover, like 19% of GP workload might have been handled better by someone other than the GP. So if you look at the pie chart here, lots of doctors say that the biggest part of the avoidable demand is potential redirection of the appointments, because patients could have often been better served if they were directed to someone else in the wider primary care team, such as even a clerk, a physician's assistant, a nurse, and instead of making direct appointment with the physician. And also there are lots of problems where patients fail to attend appointments, necessitating new GP referral again and again and again, thus wasting both the patient's time as well as the doctor's time. And lastly, there were incidences where people in the healthcare system wrongly instructed the patients to go see a GP when it could have also been handled differently. So although 74% of the services are unavoidable and is necessary, but that 26% could have been easily avoided. So to really save time and also release capacity for general practitioners, NHS this year came up with a project called the General Practice Forward View, where their main goal is to release this lost time for general practitioners so that they can see more patients and ultimately reduce the wait list. So coincidentally, right before my internship, NHS England newly launched a $126 million Great British Pounds program called the General Practice Forward View. And this program, like I talked about, is to reduce the wait list, but also increase capacity building, change things at the level of investment, as well as increase support for general practice worldwide, nationwide. So they had this goal is to, by 2020 and 2021, their goal is to free up about 10% of the GP's time and thus release capacity. And central to this general practice forward view is the 10 high impact action, which I've been involved in during my internship. So this 10 high impact action is a program which is to be implemented in all general practice across the country. And over just the past few months that I'm there, 10 high impact action have been actually implemented by a significant percentage of practice in the country. And this was quite unprecedented in NHS history. And 10 high impact actions are utilized by various clinical commissioning groups, practices, and core design and delivery team faculty members. So I'll talk more about what 10 high impact action really is more in detail. So this is the official program that the NHS Primary Care Department released. So this is each component of the 10 high impact action, which include active signposting, coming up with new consultation types, reducing did not attend, developing team, productive workflows, personal productivity, increasing partnership working, social prescribing, supporting self-care, and developing quality improvement and expertise. So to talk more about in detail about what each actions are, so active signposting is a service which provides patient a first point of contact which directs them to the most appropriate sort of help, whether it be a web-based portal or an app-based portal, which can provide patients with lots of self-help, self-management resources, as well as signposting to the most appropriate professionals. So for example, if the patient wanted some sort of an appointment, they could easily use a signposting app and find help without directly making appointments with the physician. And another second action, is the new consultation site. So instead of the traditional approach of meeting with the physician one-on-one in person, there is considerable effort happening in the NHS where lots of the appointments are actually happening by phone, email, as well as video call, thus reducing clinical contact time. And the studies showed that phone consultation actually takes about 50% less time than in-person meetings, so that would save lots of time and thus release capacity for physicians. And third action is reducing did not attend. So this would really maximize the use of appointment slots and improve continuity by reducing did not attend. And this is done by encouraging patients to write appointment cards themselves, issuing appointment reminders by text message, and making it quick for patients to cancel or rearrange an appointment. The fourth action is developing the team. So this developing the team is done by really broadening the workforce in order to reduce demand for general practitioners' time and connect patients directly with the most appropriate professional, like I talked about before. And also the fifth action is about really increasing productive workflows and by introducing new ways of working, which will enable the staff to work smarter and not harder. And the sixth action is personal productivity, which means that it's an action which really is aiming to support staff to develop their personal resilience and learn specific skills that would enable them to work in a most efficient way possible. And seventh action is partnership working. So partnership working is an active where one practice creates a collaboration or partnerships with other practices and providers in the local health as well as the social care system. So if the patient were to move offices, different general practice offices would communicate with each other, thus reduce the need to go through another lengthy appointment where the patient's information has to be collected again and again. So there are 3 more actions. The 8th is social prescribing, which is being able to use signposting as well as referral to non-medical services in the community so that they can increase well-being and independence and find services other than the family physician or the general practice itself. And the second last action is supporting self-care, and it's really helping the patients to play a greater role in their health with the methods of signposting as well as providing sources of information, services, and advice in the community. And lastly, the 10th high-impact action is developing quality improvement expertise, which is an action where a general practice team develops a specialist team of facilitators to support service redesign as well as continuous quality improvements. So these are the 10 high-impact actions, and we foresee that there are benefits for both the practice as well as the patients. So of course, as the main goal of the NHS's general practice forward view is, it would really free up the general practitioner's time. It would shorten the appointment time, reduce the error and having to do the same work over and over again because of the errors. And also it would provide the physicians with fewer distractions as well as frustrations. And lastly, staff would have higher job satisfaction. And the main benefits for the patients would be, of course, to improve appointment availability, and they would not have to wait a couple of days to get an appointment, and they would get more day after for appointments that are within 24 hours mark. And patients, because there are different kinds of actions that the GP offices are offering, they will no longer have to take time off to see the physicians because they can easily have a phone consultation and stay in their work and do their duties. Third, we foresee that there will be higher quality consultations as well as shorter wait times for the patients. And lastly, the other actions that we talked about would also improve the quality of life for the patients. So although these 10 high-impact actions have lots of benefits, there are some limitations to this program, as general practice in UK has never received this amount of investment as well as time for service improvement and as well as program uptake within their practice. So, for example, in Canada, most GPs have a list of their patients and they just focus on treating them when the patients come in. And this is really similar in UK as well, where the doctor has their own office and they see a list of their patients if there are appointments. So they've never really prioritized their time in terms of service improvement as well as organization. Also, because there are these are 10 actions which general practices have to implement, it really is time consuming to learn as well as to see if it works well, or it might actually hinder productivity in certain settings. And lastly, most importantly, there is this uncertain effect in terms of releasing time and increasing productivity as well as capacity. So that's where majority of my project was, to really attack this limitation. So how do we really encourage implementation of 10 high-impact actions? So first, we believe that if there is a concrete metric for quantifying general practitioners' work, they would be able to implement this action and see visible improvements happening within their practice. And also, publishing protocols and instructions on how to implement these 10 high-impact actions would really help GPs to provide these services in a more consistent manner. And also, there will be also an increase in implementation if there are lots of training programs offered by the NHS. And lastly, the GP Capacity Forum, as well as case studies, would really encourage implementation. And I'll talk more about each of these points later on in my presentation. So, this is the GP Capacity Forum. And General Practice Capacity Forum has these individual 10 high-impact actions, as you can see on the screen, There's a thread for active signposting. There's a thread for new consultation types where under each thread there are real case studies and reports from each general practitioners around the UK talking about their experiences using this 10 high-impact action. So as you can see, there aren't that many entries because it is a new program which NHS launched, but it was even lower when I first started. And this page is mainly used for current GPs really talking about their successes as well as also fallbacks to troubleshoot each actions in the process of implementing these 10 high-impact actions. And because this forum is public, it is also for general practitioners who are really considering about implementing these 10 high-impact actions. So as one of my projects was to really contact and talk to these various general practice offices that are implementing 10 high-impact actions and have in-person meetings as well as exchange communication with them to see and hear about their successes and also their failures from using 10 high-impact actions. So because this is, in a way, a database, we wanted to really increase the amount of, I guess, testimonials of different practice using the 10 high-impact actions so that people who are uncertain about can actually go on and see that these 10 high-impact actions are actually working and is being implemented in the field. And going back to one of the limitations we talked about, so 10 high-impact action currently does not have a solid metric because even if you implement these 10 high-impact actions, each general practices really don't know whether or not this is working because there's no quantifiable measure for it. So therefore, one of my projects really was to work with the General Practice Board, the director, Dr. Robert Barney, to create a quantifiable metric to define and measure physician productivity. So the steps of really coming up with some sort of an empirical measure was to develop a potential metric by revamping the relative value units for each 10 high-impact actions, and also creating practical guidelines for local practices to utilize and measure the effectiveness of 10 high-impact actions. So this means that by following these formulas or guidelines, each general practitioners would be able to monitor their improvement or perhaps their decrease in productivity through this formula. And lastly, the steps included assessing the validity of metrics when measuring general practices' release time, work, and productivity in practices. So of course, the population that we really looked at is the general practice offices across UK, and the intervention is 10 high-impact actions. So whether or not the 10 high-impact action is helpful for GPs or not. And the outcome really that we're trying to measure is the time released from general practice after implementing 10 high-impact actions. So there have been attempts in the past to measure productivity, and there are some literature about measuring physician productivity, but these metrics really only include quantification of financial metric and the number of patients, treatment, and appointment per full-time physician. So this metric really neglects other confounding factors such as skill, number of staff, expertise, all of which can really skew the measurements of productivity in each individual general practice offices. So to address this criticism, there is this metric called the relative value units, and we believe that this can be used for 10 high-impact actions because it does not only just consider the number of patients that we're treating as well as the number of staff that we have. So it really attempts to quantify standardized clinician work by measuring the time, skill, expertise, the work intensity, rent, supplies, staff, equipment, professional liability, as well as insurance. So as you can see in these figures, instead it's not just a financial metric, but it's actually a metric that considers lots of different aspects that can happen in the general practice. So these are some of the formulas that can be found in relative value units that we've developed. So I won't repeat all the formulas, but these formulas can be used to assess the before and after implementing the 10 high-impact actions. And the general practitioners actually using this formula could be actually could be counterintuitive because they would have to take extra time to measure and calculate all these things. So we expect that this relative value units for 10 high impact actions would be implemented to hospital clerks, research coordinators, or administrative staff so that they can measure the difference between before and after. So in terms of developing this new metric, we provided an initial draft of guidelines to general practitioners containing metrics that can measure general practice productivity. And we have a few general practice offices which have volunteered to use this metric and pilot the validity of the tool. So we first need to see if this tool can actually be useful for measuring productivity before making all the GPs around the country to use it. And also our guideline as well as the recommendation for the metric is being approved in the NHS so they can gain confidence that these metrics are practical as well as plausible in practices right now. So another role that I played in the National Primary Care Department was to attend and assist with these training as well as showcase events. So during my internship, I really had the opportunity to attend many, many events. And almost every week, I had the opportunity to attend these region-wide NHS events where our department was able to present our work on the 10 high impact action and also talk to local general practitioners about this program. So it was a really neat opportunity for me to not only interact with general practitioners in the UK, but also to just travel around London as well as other parts of the UK, such as Lincolnshire, Chester, Liverpool, Humber Coast, and etc. So this event really is to help these GPs who are interested in 10 high impact action to uptake this program and utilize within their practice. So in these events, I really assisted as well as helped facilitate the conversation between GPs from a variety of clinician and commissioning groups. So as you can see in the picture, there are lots of roundtables around this event where lots of GPs sit down and they talk about their experiences about the 10 high impact actions. And also the GPs who are not using 10 high impact actions can actually talk to each other and exchange feedback and advice. Finally, another role that I played in the primary care department as well as outside NHS England was to review and assess different web-based apps for general practice. So unlike the Canadian healthcare system, UK has hundreds of different healthcare apps that are being developed by physician groups, healthcare practitioners, as well as local startups. So there are lots of apps and web-based portals that GPs or specialists can use to improve their practice. So to give you an example of one, this is one of the most promising web-based portals that are implemented to about 20% of the general practices in the UK. It's called the e-consult web GP system. And this would fall under the second category of the 10 high impact action, which is the new consultation type. So to explain how this portal works, so when the patient is sick, they can either go to e-consult, which is the app, and they would answer about, I believe, over 50 questions pertaining their patient history as well as their condition. And this list of questions and results would be then mailed to the clinician. And the clinician can just simply review this file on their computer. And after reading these completed questionnaires, the patients would either be offered prescription, or they would simply have telephone consultations, or they can be offered an appointment if it's more of a severe case. So as you can see, about 60% of the services can be actually managed remotely, thus releasing time. So the NHS, of course, is not directly related to this app, but they're always looking for different app and web-based portals that can really improve and help release this time for the GPs. So these are some of the projects that I worked on during my time in the UK this summer. So although I felt like I didn't have much background in policy development as well as policy-related research, the various events as well as the team that I work with really provided me with a solid foundation to continue my project and also give back to the program as well. So moving on to the next part of the presentation, I just want to talk about my overall experience as a QE scholar in UK. So throughout my time in London, specifically, I had a chance to attend lots of informative events. So as you can see in the picture on the left, it was really an opportune time for me to attend the annual eHealth conference, which is a yearly nationwide conference where a variety of people ranging from physicians, policymakers, engineers, all come together to share these new technological advances in the UK healthcare system. So it's about a 2 to 3 day long conference where people who have developed these different healthcare-related apps come in and really showcase how it can help the health system as a whole. So it was really interesting to see how much interest is in the digital aspect of healthcare, which compared to Canada, which does not have much technology or apps being currently implemented within the healthcare system. And another really cool booth that I came across was called Lifelight, where when a patient simply comes into the ER and fills out their information, they actually have a device which measures the patient's heart rate, respiratory rate, as well as their blood pressure just by looking at the screen. So that was really interesting because that in itself would really save lots of time and reduce the wait list in the emerge if it were to be implemented in Canada, which has a long wait list in the ER as well as in other primary care settings. So also, there are lots of free public talks at London School of Hygiene and Tropical Medicine, as well as London School of Economics, where it really allowed me to learn more about the NHS and the history of NHS, as well as other things that are happening in the UK health system. And although the talks are oftentimes quite detailed, and truthfully I did not understand much at times, but it was still nice to get some exposure to the topic and really listen to what's happening in UK and London. Also, this year, of course, was Canada's 150 as well as Ontario's 150. So it was an opportune time for me to interact with Canadians in the United Kingdom. So I actually was able to attend this event where it was a celebration event called the Ontario 150, where it next happens. So it was an event where Canadian people living in UK came in to just network and celebrate Canada's 150 as well as Ontario's 150. So it was really nice to interact with these Canadians. So some of the people that I interacted was Portuguese ambassador, the vice president of RBC in terms of artificial intelligence, and also Ontario's Minister of Finance as well as Ontario's Minister of International Trade. So it was nice to talk to them, network with them, and also tell them about what I'm doing at the NHS and what the QES program is as well. So it was really nice to feel like home, and it was nice representing the McMaster Health Forum as well. So during my time in London, I realized that London is also a very diverse country, just like Canada. However, unlike Canada, where everyone is living together, so often Canada is often described as a nation sewn together into a quilt, but London is diverse, but it's slightly different from Canada. So as you can see in the picture, depending on the subway station, there are actually small ethnic enclaves depending on the subway station. So one station would have lots of people from New Zealand, one station would have lots of people from Somalia, and the area that I lived in central London had lots of Hispanic people. So depending on where you are in London, you can actually pretty much experience different parts of the world and explore their culture as well. And another part that I really enjoyed about the Queen Elizabeth Scholar Program is to interact with other QE scholars in London as well as UK. So during the internship, because it is, of course, 92 days away from home, it can get at times quite lonely. So I've always missed my friends and family, but connecting with other QE scholars really helped me to feel better, be more resilient, and made the experience a lot more fun. So we were able to share our experience living away from home, and we were able to tour around different places during the weekends, and also at times exchange feedback on each other's projects as well as their internship experiences. And lastly, London, of course, has lots of tourism. They often call London to be a city, I guess, the earth or the nation's capital. And every day to work, because the Skipton House was at central London, I had the chance to walk by some of the best landmarks and tourism sites in London. So I was able to see the London Eye, the Big Ben, and London Bridge, which was all 10 minutes within my workplace. So if anyone were to go to London, I would definitely recommend checking these sites out. And for anyone that is planning to do an internship or is planning to visit the UK, these are some of my tips. Housing can be quite expensive in London, and everything else, of course, can be expensive in London, so I would definitely plan out the budget beforehand. And also transportation, unlike perhaps the Toronto's TTC, the subway line can be very confusing at first, so it takes some time to get used to. And the weather in London is quite unpredictable, so sometimes it gets cold, it rains almost every other day, so it's really nice to have some sort of a raincoat or weather protective wear. So lastly, I want to give special thanks to many people that provided me with this opportunity, and this really was an experience which I'll carry on forever as I proceed through my career in medicine as well as healthcare. And I would like to thank the McMaster Health Forum, Dr. Levis, as well as James, and QES program, the Rideau Hall Foundation, Community Foundations of Canada, and Universities Canada, which really created this QES initiative. And lastly, I want to give a huge thanks to everyone in the NHS England's primary care department, Dr. Arvind Madan, who is the National Director of Primary Care, Dr. Robert Barnum, Kathy, Eden, and everyone involved throughout the process. Thank you.
All right, thank you, Jan. Very interesting, very informative presentation. For those of you who are in the room with us and those of you who are online, feel free to ask your questions. If you're online, please type your question in the chat box. I'll ask a question to get things started. So spent a lot of, obviously, working with the primary care group, spent a lot of time learning about the primary care structure within England. So here in Ontario, we basically have 4 models of primary care. We have family health teams, community access centers, Aboriginal health access centers, and then a nurse practitioner-led clinics are the basic 4 models that we have. What are the models that they have for primary care in England? Do they translate to us here in Ontario?
Right. The primary care model actually is quite similar to Canada. There is community care aspect, there is the home care aspect there, as well as there's the family health care team. I don't think they call it specifically family health teams, but they do have these individual offices. But as a medical student, as I now do different kind of shadowing and different kinds of family medicine specialties or just different kind of offices, it was really interesting to see how in the UK, lots of family doctors have video consultation offered to their patients, and oftentimes I was able to talk to the GP about how they come in at like 5 or 6 a.m. in the morning. That's when they start their clinic, and they actually just spend the first hour or two looking over these, I guess, the web consults, where they can just simply check off, oh, this patient needs prescription, this patient needs an appointment. So they do these like administrative work before for about 2 hours, so they can get those patients over with, and they start the in-person practices. So in a way, Canada has this appointment system, but lots of the GPs in UK have this structured system where they want to see as many patients as possible by using both, I guess, these web-based apps or portals within their practice so that they can run a lot smoother.
Interesting. And then that's a nice segue into actually my second question, which was about that second piece that you were working on, the web and the app type perspective. That's something that here in Ontario we have played with over the years, and it seems to fall to each almost individual family health team as to how they approach that. The big issue that always comes up, you'll hear here, is privacy, patient privacy. People are hesitant to use online things, apps, those types of things. And from one family health team to another, you'll have very different opinions about whether those should be used and how the extent to which they should be used. So I'm just curious, the system as it's set up in England in terms of privacy and patient records and those types of things, how has it fostered the development of that we could maybe learn from here in Ontario at least?
Right. So I think that in itself is quite practice dependent as well in the UK, but since the health system is slightly different from Canada in a sense that physicians are commissioned by the NHS, so in a way, lots of the patient information definitely can be under risk for, I guess, hacking. I think during my internship, I think May or April of it, I think NHS was hacked, and there was a huge hassle about how this patient information could have been leaked, and there are lots of, I guess, problem within the NHS. So I think now they're more sensitive to the issue, for sure. I remember starting my first day where people who are working in the NHS actually use the laptops provided by the NHS, and they all have NHS-specific emails. So all the doctors in UK have, let's say, like young.lee@nhs.uk, so that all the information is really controlled by a single security system. So I assume that the patient information and how they're protected is similar to that. But I definitely do understand the point about how these web-based things can put patient information under risk, for sure. But it's interesting to see how lots of physicians in UK are more receptive to using these digital apps than Canadian physicians nowadays, yeah.
Interesting. Again, I'll put out a call to anyone online. Feel free to type your questions in the chat box. Anyone else in the room have a question, feel free to put your hand up. So I've asked you 2 systems questions. I have to ask a traveling question. So as a visitor in the UK, you know, you had the opportunity to meet up with some of our other Kiwi scholars, but what is it about the UK that you really, really enjoyed that was unique from, you know, living in Canada that you can tell people about?
Right. So I think for me, UK in a way is very diverse like Canada, but I think what I really liked about UK is that there are so many, I guess, famous institutions as well as like they often say NHS is like the role model healthcare system of the world. So I think as an aspiring physician, it was really nice to see and be part of this whole health system where I can learn from not only the doctors or policymakers, but also just be involved in this whole community where lots of the new things were developed. So for example, when doctors here are certified, I think they go through the Royal College, which is based in the UK. So going to like an event hosted by the Royal Society of Medicine, or going to like events such as like the LSC or the London School of Hygiene and Tropical Medicine, like those things are just like a walk away from where I was living. So it was just like, it felt like London in itself was a huge classroom for me rather than going to NHS just for work. So I could just go anywhere to learn and explore and just interact with people from different cultures as well.
Great, wonderful. We'll draw to a close. I'll just point you to the links that are on the screen at this point in time. So the first link is a link to our scholarship program here at the Forum. So please visit that link for more information about our program, which will be continuing through 2018. The second link is a link to our Queen Elizabeth Scholar webinar. So this is one of many. So please visit that link, get a list of all of our current, past, and future webinars when they are scheduled. And the third link is to our Queen Elizabeth Scholars blog. All of our scholars write a blog about their experiences, and we post it on that website. So please visit it, give them a read, understand what all of our scholars have been doing outside of the work that they do while they're on their internships. You'll get that through the blog post. Young showed a picture of 2 of our other scholars that he visited with. So Abby and Matthew were in that photograph. They have both done their webinars. So please visit our webinar page, and you'll see their webinars as well about their experiences at NHS Oxford for Abby and for the B&J PAC program for Matthew. And Young's, of course, thank you very much, Young, for coming in, and we appreciate your presentation. Very informative, and we appreciate you taking the time away from your medical studies. And thank you, everyone, for joining us, and hopefully we will see you all again soon. Bye-bye.